really glad to talk about this little unusual topic. But despite being unusual, I think there is highly required need to openly discuss about it. So how did it all start? As you are aware, the diversity, equity, and inclusion committees now have become mandatory by law for almost all the organizations. When we thought about having any such topic in ISCCM group, there was the first of all resistance saying that is it really a concern or are we wasting time? And when we presented it during our recent conference, I asked the audience, whosoever feels it is not a concern, please raise your hands. And I would say the same thing over here. And at the end of all this discussion, we will again revisit this question. Diversity, equity, and inclusivity. It is not only for women, but it includes any other disadvantaged subgroup needing support for equity. And we know this in our society, especially in India. We are actually giving a lot of importance to this. How did it occur to me? Actually, it is 30 years since the inception, more than 25 years since the inception of ISCCM. I had been a founder member for this. And this was the first year when we had a woman president. And it actually started making all of us think. But a personal experience to share. When I was traveling, especially in Gujarat and Rajasthan area, I had a lot of alumni who had passed out from Ruby Hall, worked under me and heading various ICUs. And when I was talking to them, I just casually asked, how many of you have got women intensivists working in your groups? And everybody started looking at each other's face and with, madam, then leaves and this and that. And I was so shocked. I said, you worked in our unit and you are having such biases. And what is the reality? That was in my mind, and it was so great that the same thing reverberated while developing research committees in ISCCM. So we started looking at what is the situation in our own field of critical care medicine. And we started with ISCCM first. So the membership graph, I think, is very self-explanatory, which you can see over here, that the membership of women itself is so low and so slowly growing. It has become 3-digit only in 2012. I have been in this field for almost 30 years now. I have been fortunate to mentor a lot of women students as well. But looking at all this situation, I really started thinking about it. And this is in the organized sector. Many are in unorganized sector who don't even get counted over here. And what exactly is happening? So as this cartoon depicts, you really have to be doubly good to be equal. It's true for disadvantaged or underrepresented sectors, of which women is one of the groups. And we need to look at it, need to understand the reality, and need to do something about it. A lot of times it is said that a woman herself is responsible for her non-progress. I'm really so glad to look at your society and anesthesiology and gynae obstetrics. I think it is blessed for women because it is considered as a domain for them. But while coming to critical care, there could be a different outlook altogether. So we decided to find out what is this reality. The term gender refers to the characteristics of women, men, girls, and boys, and transgenders, which include the norms in the society, the behavior, and the roles which they take up. And it is probably associated with being a specific gender. So when we started thinking about diversity, one of the most important group which got disadvantaged came up as gender, and that is why initially we started with this, but it is not restricted to this, and we are going to study various different backgrounds as well. So gender equity is a process to ensure fairness to men and women. Remember that. It should help women who are historically and culturally disadvantaged and should offer a level playing field. So what is this concept of equity? And number of times we misunderstand equity with equality. How do women look at themselves is also an equally important question. It is not only in India, but world over. We try to find out what is happening globally. So in 1968, it was a famous statement by Shirley that women look at themselves to be all right for the roles of secretaries, librarians, teachers, but less unacceptable for them to be managers, administrators, doctors, lawyers, and member of Congress or in the leadership position. Well, the things have changed quite a lot, and I'm sure we all belong to a very elite group that somehow we have come to this level. But we have to look at everyone. And the question or the point which is always pointed at is that the women are trying to suppress other women, how women treat other women, and whether whatever happens in the family, which is very well known, does that also happen in professional roles, or women are better mentors for women? It is quite amusing to see how the panel was chosen. This tribate, we were all women. There was not a male candidate in here. But then it is really important for introspection. Again, this cartoon, I think, is very, very well depicted, which tells us about equity. And equity recognizes that each person has different circumstances and allocates the exact resources and opportunities needed to reach an equal outcome. So we have to work on mentoring them. And then through a long process, which we reached to the ISCCM position statement on gender balance in critical care, which we were really happy and fortunate to present at the ISCCM conference in Kolkata. So is it really necessary to even have such discussions and committees? More than 70 years of Constitution of India, and we are still talking about equity, equality, despite diversity to every citizen. And still the efforts are needed to enforce it in the society. Similarly, 30 years since foundation of ISCCM, but the first woman could become a president only now. So we at least need to talk about this. And there was a long felt need to address gender balance to represent women in various committees. So from our personal communication with the membership office, what we found that out of total membership of 15,800, male members were 11,600 and female members were hardly 4,200. Transgenders 3. And I think this also we need to look at as the time is advancing and people are coming forward openly to discuss about it. So current executive committee members, again, there is a shortfall of women, more than 25 years of existence, still there was no female president till now. There were a total of 187 founder members, of which very few were females. And position statements in last 10 years, which were published in Indian Journal of Critical Care Medicine, the average female authorship among these papers was very, very minuscule. So we conducted 2 nationwide surveys, and after those surveys, we conducted a Delphi consensus through which we came up with the position statement. We will share the position statement later on because we do not have enough time to discuss about that. I'm just discussing the background and the process. So there were female respondents for this survey, only 39%. So actually the male members responding were more when we were talking about the problems in career progression. So age group 25 to 35 were 50%, women taking career break 1 to 3 years were 50%, and which is a natural cycle. We all understand that. But because of this break, what happens to their career? How does it affect their career is one of the most important questions. Feeling of unsatisfactory career progression in female consultants, almost 50% felt it because of that. And the reason given for improper career progression was being a female gender, 17.6%, maternity breaks 13%, and family and kids 21%. And obviously, these are the natural instincts with which we are born. But the support from the family, support from the society, and support from the professional colleagues and administrators of the institutes is equally important. One of the very important points which came forward was the pay gap. Pay gap was significant, as mentioned, by 42%. And then the second survey, was about the gender equality in critical care. So this had a very large number of questions pertaining to trying to pick up the subtleties in this. So there were less number of women who were heading the ICUs, but there were some very, very basic things, that there were no separate changing rooms in almost 62% of working environments. The depression was found more to be in women, but anxiety and panic attacks or the burnout-like symptoms were found almost equally in both the genders. There was no support from spouse or family, was clearly mentioned by 15% of women, and total responsibility of household chores was mentioned by women. And even if little bit of support in the family in day-to-day work was very gratefully mentioned by women. Many of them, like 40 to 50%, felt that there was poor representation in the society, ISCCM, and lack of opportunities in ISCCM or in elections for women. Probably it cannot be managed. But do you know, in informal discussion, one of the senior members said that, oh, we realized that women also can speak well. And that was a shock to all of us. No maternity benefits or flexible hours or nursing breaks was mentioned by almost 50% of women respondents. And this is really, by law, India gives good maternity benefit to women in this work group, in this age group, who are professionals. But in private sector, it is not so. Maybe the government sector, they have to abide by the rules. But in private sector, when I was checking informally with the various HR departments or even the nurses, nursing superintendents who would interview the nurses, whether they ask the question about whether you are going family way, are you planning pregnancy, or how is the family situation, was one of the deterrents to offer the post to women aspirants. And it was again very shocking. And if you're aware, when these societies are more strong in developed countries, these questions are prohibited from asking in the interview panels. Career compromise due to family responsibilities was mentioned by 50% almost of women. Now, again, there is always a question whether you want to go strong on career and neglect your children. Now, why this should be either or? And if there is equal support, then this can very easily be gone through during this age group of between 25 to 40, which is intensive on both the fronts for a woman. I'm really very happy to mention here that I have been in the field of critical care for almost 30 years. I started when such specialty was not even known to many of our fraternity. But I'm really so grateful to mention about the support of my families on both the sides and my husband, despite being a non-medico, and my son. So only with the support and understanding from these members in the family, I could go ahead, and I'm really willing to do it all over again. But I'm really happy to tell this to our members that if we look at both these sides, then we can go ahead and give a lot of representation and career progression to women. Dr. Urvi and myself, we wrote this article, and I'm really suggesting you to go through the original article. I'll very quickly go through some of the findings. And there was a national survey on higher education, which could find that actually in students, 53% of women were in undergraduates. Courses chosen were quite different, as it is mentioned over here. In medical science stream also, states like Kerala, 55% female students in MBBS. But at PG level, it gradually starts falling. And it is bad to see that allopathic doctors in clinical practice in India as specialists or super specialists are very, very small. In rural areas, even smaller. So it is quite clear that women start facing the problem right from the female feticide and unequal exposure to basic education, unequal burden on the girl child when the family faces financial, social distress. Traditional and cultural upbringing reinforces the attributes which are inequality in both women and men. This is clearly seen in the way women choose educational streams and employment. Women are faced with workplace discrimination. I'm really sad here to mention this, but it comes they are considered to be lacking leadership qualities. This is one very important bias which is there in the society and the professional colleagues and the administrators. So critical care medicine has been considered a domain for males largely due to long and irregular hours and stressful work. And this is true world over. Women fall prey to an irrational prejudice in clinical practice where people prefer even a mediocre male doctor to an excellent female physician. And we all have experienced this. After everything is done, they would say, but will you please call a senior doctor? Now, with my gray hair, I don't face this problem anymore, but otherwise, I have faced this problem number of times. So inadequate progress in academic medicine is found even in the US in the national faculty. And these are the numbers which are very clearly mentioning this. There is lack of parity in rank and leadership, lack of equity in pay, lack of retention of women in medicine, and fairly large burden of family responsibilities and work-life balance problems in career progression. So if a family member is sick at home, we all know that it is a very, very natural tendency of a woman in the family to take responsibility and miss the work. And then the absenteeism at work, when it is looked at, it is staggering. I always tell my junior doctors, women, that please, if you want to be equal, to be considered equal, please, you have to be equal while taking the responsibilities and not shy away from it. But sometimes, the family expectations are also different. And sometimes it's very difficult to choose career at the cost of family, at the cost of marriage. And this is not unusual. A report from UK also found similar thing what was found in UK, and payouts were different. There was a better pay equity in the nurses more than doctors. So that also is something to be looked at. The female first authorship in publications is quite less. There is an article in any gem which talks about this. And this is a stark reality from all developed countries as well. You would be surprised at the guidelines which we follow. In European Society of Intensive Care Medicine, which crafted the third international consensus definition along with SCCM, there were no women panelists and no physicians from low and medium income countries. So it is a very stark diversity or discrimination, if we can say. We have already talked about this. So in Indian context, everything is true, what I have mentioned till now. There are some very interesting papers. A total of 1.5 million hospitalized patients of more than 65 years of age looked at their 30 days mortality. This study looked at, and keeping all other factors constant, patients of female physicians had a smaller but significantly less mortality. And the patients mentioned in their study that female physicians practice medicine differently, probably giving more time and patience to their patients rather more than their male colleagues. So there are certain qualities which are there in female practitioners. While talking to dropouts, it is even worse. Aspiring women candidates more likely to leave competitive medicine for non-profit organizations, and they search for part-time jobs very early in their career. This is where they stand to lose out on career progression. They are also less likely to talk about the discrimination. It is taken for granted. At the workplace, it is important to talk about this, about any type of harassment, more likely to face burnout, depression, talk about it, and many women quit clinical practice altogether due to inability to voice the multi-pronged problems. But with this, I would want many of our colleagues to come forward and speak about your own problem, because that is the first step of empowerment. We know Dr. Anandibai Joshi, who has always been my guiding star. Exactly 100 years ago, this lady faced huge number of problems, faced a lot of negativism, but she was one of the first graduates in modern medicine and tried to come back to serve Indian women. But a lot of them miss this opportunity in the struggle to fight and the bias. So we have to start looking at it, whether we can find the cracks in the glass ceiling at individual level, at organizational level, at family level, and in societal level. So in just few minutes, I will talk about this and stop. So we all have to first have to take the pledge that we will try to reduce any type of discrimination based on diversity, equity, and inclusion problems. So is there any thoughtful and sensitive person now in the audience who would not agree that DEI is a concern and we need to work on it? So at individual level, grooming and avoiding dropouts and mentorship and support to develop work-life balance and building resilience in women workforce in critical care medicine is very, very important. Personal problems are not a shame, but it is a reality. And doctors should be encouraged to speak out about them and find the reasonable solutions. So what can be done at organizational level? Sensitization towards gender equity, males or female senior faculty members to help or guide to overcome career obstacles. It is not necessarily that only women mentors should be there. There can be men with very broad outlooks. Consciously nominating women for opportunities to be speakers, panelists, and leaders in the conferences. Women should constitute an equal percent of speakers, panelists, and experts in conferences. They can, definitely they can. So organizational levels only on paper, where there are so many things like maternity leaves, pay parities, etc. So there are stories of refusing to employ women with young children. There are numerous ones. Even for posts for DNB, it is taken in writing at some institutions that you will not become pregnant during the tenure of DNB. Institutional audits to monitor pay parity are important. Maternity benefits and paternity benefits as well to be compulsory, to be made compulsory across the country as per national law. Conscious attempts to increase women at senior positions in the organization, because it definitely helps to develop more balanced view. So what should happen when we are not professionally supported? Factually, the women who fulfill their natural role to bear children and raise them make compromises at the career level, at the prime time of career. And we all have to keep on thinking how we can help them, how we can groom them. So the first lady editor of JAMA had said, we waste half our genetic pool of intelligence, creativity, critical insight, and experience if we are neglecting women. So simply we cannot afford that loss. So at the conclusion, a woman has to be doubly good to be equal is the truth many of us have experienced. And it is the time that as a medical fraternity, we have to give a serious thought to it. Overcoming gender bias is for collective good of the society, patients, and the physicians themselves. Thank you very much for giving me time.